So I have 30 minutes. I'm going to take 20 minutes, and I'm going to run through talking about some things that are impacting cancer care, starting out with the shenanigans that are going on in D.C. about trying to repeal and replace the ACA, or Obamacare as it's affectionately known. And then I'll touch on a couple other little pieces of legislation and issues that are impacting cancer care. And then saved 10 minutes for questions. So we'll run through this. Just real fast, though, is just a brief overview. People who don't know COA, it's a nonprofit organization totally dedicated to community oncology. It's been in existence 15 years. The governance is by a board of 35 individuals. Most of those are oncologists. Some are practice administrators. And actually, some of the representation at the oncology level are the biggest independent oncology practices in the country, including Florida Cancer Specialists, Tennessee Oncology, Texas Oncology. And basically, we do two things. Number one is help practices network, connect, share best practices, and provide them with the latest tools. We do that through a number of different forums, and then advocate for practice and patients both on Capitol Hill and across the country. So we have a big patient advocacy arm as well, too. Just a little blurb in terms of the mission statement. We strive to ensure that cancer patients receive quality, affordable, and accessible cancer care, which is physician-directed in their own communities. And this actually took the board a lot. It sounds like a throwaway statement, but it took the board a lot of time to come up with. And because I live in the world of policy, I will give you a couple full disclosures. Number one is I spend way too much time on Capitol Hill. And just be thankful that you don't have to spend a lot of time on Capitol Hill, because it's about the most dysfunctional place, I think, on the planet recently. Little disclosure is because I spend a lot of time on Capitol Hill, and I come back to my wife, we're empty nesters, and I talk about all these policy things and some that I'm going to touch on. She looks me straight in the eyes. She doesn't want to talk about that. She says, I want to talk about my 41-year-old lung cancer patient with 3 kids who will likely die. And let me give you a dose of reality, because my wife is an oncology nurse. So we live in kind of this bizarre world of cancer. We talk about the weather, it comes back to cancer. We talk about golf, it comes back to cancer. So she does a good job of keeping me honest and grounded. So the first thing I'm going to do is I'm going to touch upon the ACA and Obamacare and give you some major problems. These are not the political problems, but the structural problems. Another bit of disclosure. Those of you know I'm a classic Connecticut independent, so don't take anything as I say as a political statement. I tried being a Republican, I tried being a Democrat, it doesn't work, and it's not that I can't make my mind up, but I look at myself as an American, and I just don't have to identify with a party. So don't take anything I say as political as much as just this is the way it is. The U.S. and counties with only one insurer have increased 5 times from 2016 to 2017. So does everybody know what that means in terms of having one insurer, what happens? If you have one insurer in a county, what happens? Yeah, rates go up. So what's happened is premiums have increased as insurance competition has decreased. Insurers need subsidies to make exchange participation profitable. So right now there's actually a case that's gone up to the Supreme Court about subsidies, and the insurers will tell you that they basically need those to keep the exchanges profitable and keep them in that. Even this week we've heard some things come out about 1 or 2 insurers that are looking, including Anthem, of backing out of the exchanges. And one of the problems here is the goal of younger, healthier individuals participating on the exchanges have not been realized. What does that mean? If you look at the way they actually scored, or they mapped out this bill to see what it would cost, what it would save, they banked on a lot of younger people. Younger people are healthier. They don't use up healthcare resources and therefore file for insurance. So it makes the insurers more money. That hasn't happened. The biggest single group is the pre-Medicare group, so it's been a real problem. The other problem is the co-ops are a failure. So whatever your political disposition here is, the bottom line is this would have had to be opened up because it is a problem. Now what I'm going to do is just give you the obvious should be to everybody is that when you take a look at cancer care and you look at some of the most important provisions, there's a lot of provisions that impact cancer care and funding for research, but the first one is obviously more individuals are covered by insurance. So that's an obvious one. There's no discrimination against pre-existing conditions at all. A big one, why someone gets cancer, basically want them to be able to have insurance, especially if they have a pre-existing condition. And a really big one is if you look at cancer care, obviously because it's so expensive, you don't want lifetime or annual caps hitting because you're going to hit those with cancer care. You won't with the sore throat. And obviously patients before, people before who hit those and had to shell out their own money, that can really cause financial ruin. So now I'm going to get into a little bit of the politics around this. So you have the hardline right Republicans. They want it repealed immediately. They don't want to talk about replacing. They want it repealed. Now, I will tell you that repealing it immediately doesn't mean that people or individuals are going to be on the streets without insurance and all the provisions in the ACA or Obamacare are going to go away. It would mean that effectively around 2019 you would start seeing changes. So it doesn't mean that, but it's still repeal it. We don't want to talk replace, get it out. Most Republicans, I can tell you, want it repealed and replaced either somewhere between immediately or very soon. The president campaigned on the promise of repealing and replacing it immediately. That was part of his campaign platform. The hardline left Democrats don't want it touched. They literally are almost in denial, don't want it touched. I think most Democrats realize that it will have to be opened at some time and fixed, as I said, because of some of the inherent problems with it. And right now I can tell you there is really bad, I could have repeated the word bad election blood flowing on Capitol Hill. And the blood on Capitol Hill didn't get any better today, because do we know what happened today? Supreme Court justice. So, and yesterday, as you know, the Republicans in the Senate went nuclear, which means that from now on, the Supreme Court justice will only require a majority of votes in the Senate, not 60. So this has really created a lot of problems because the Democrats feel, and those, I don't know, anybody see, watch Meet, I'm such a junkie, it's terrible, I don't have a life, but anybody watch Meet the Press on Sunday and see, so you saw probably Senator Schumer talk about the fact that, with Merrick Garland, they felt they did not get their choice, didn't even get a hearing, and now all of a sudden they have Gorsuch rammed down their throats. So there's a lot of bad blood, and what that does is it makes bad blood in terms of trying to solve health care, and it makes bad blood in terms of when we look at the impact on cancer care. The state of the repeal and replace legislation is this. The first attempt was by the House Republicans, as you know. It failed. The bill was pulled. There was no vote on a Friday. The House Republicans literally tried to pull a rabbit out of the hat before Easter. That's a funny line. Laugh at it. There was a failed attempt. Literally, they tried to do that this week. I left D.C. They were holding out all hope. But there was no bill, no vote, nothing except setting in motion basically to tackle this when you come back 2 to 3 weeks when Congress returns. And I actually think they may. I think they're on recess, Congress, for 2 weeks, spring, Easter recess, whatever you want to call it. And the bottom line is I think they will try it again. The Republicans are very much of a divided House, and that's part of the problem because no Democrats want to vote for this in the House. And basically, you have the Freedom Caucus, that's the hard right, wants immediate repeal. And the Tuesday group, that is the moderates, they actually, as you can imagine, meet Tuesday evenings. They want sort of a softer approach to replace and repeal. And there's a lot of arguing going back right now about essential health benefits. There are 10 essential health benefits that that have to be included in the policies on the exchanges, and that's where you see a lot of the argument. The Senate Republicans are looking at this and just saying and shaking their heads. You know, as crazy as the Senate has been this week because of what happened, Republicans there a little softer. You don't have, except with the exception of Mike Lee, Rand Paul, Ted Cruz, you have a little bit more moderate look at this. So regardless of what the House does, I don't see how, unless they really configure an absolute middle course, how it's going to get passed in the Senate. But never say never. I'm going to touch upon in the next 10 minutes some other cancer care issues, and then I'll leave room for questions, or I'll do a little soft shoe for 10 minutes. Several bills dealing with aspects of drug pricing. It's a very popular topic, and I'll touch upon some things related. I'll show you a couple bits of information related to actual data that has to deal with drug pricing issue. There are companion bills in the House and the Senate on oncology payment reform. They were developed around the oncology medical home model. We've spent a lot of time at COA, a lot of oncologists dealing with the oncology, developing the oncology medical home model, and actually having private insurers, working with private insurers and Medicare. Does anybody know the oncology care model? Does anybody know it, participating? Well, that's a Medicare model that's out there, and it's really an oncology medical home, and that's there are now two bills, one in the House and the Senate, and they're serious bills because the bill in the Senate, usually you don't have the number 2 person in the Senate, John Cornyn, basically sponsor a bill, but has. There are bills in the House and the Senate to curb pharmacy benefit managers. You're going to hear more about PBM abuses. I'll just touch upon this in a minute. And there's a bill coming up on creating greater transparency and accountability in the 340B drug discount program. Does anybody know what that is? That's a program, 340B is a program where basically nonprofit hospitals that qualify and other entities, including Ryan White, AIDS clinics, and community health centers, get discounts. It's a program that's grown enormously on the hospital side, and there's greater awareness of this and problems with this, even in terms of fueling the drug price side of it. So obviously, you know, everybody knows the headlines on and on and on and on about drug prices front and center. The president will not let it go. I think when a Republican was elected president, the drug companies jumped up and down and basically said this is a good thing. And the president now is not letting go of the issue. And I can tell you, in terms of the different agencies involved, including the Office of Management and Budget, obviously key, we'll actually be for a meeting this Wednesday, is they're not letting go of this idea of tackling the drug price side. So you are going to see some action where you normally wouldn't think you would get action on drug prices from a Republican president. I'm just very fast breaking down the issue. Drug prices are, I don't think, everybody agrees, are a problem. I certainly think they are. They're not sustainable. And when I look at it, and I'm specifically talking about cancer care, and I think that bio and pharma companies, I say this everywhere I speak, I say it closed doors. I've literally been with the top leadership of company after company, and I've said, you've got to get a handle on this. But I will tell you, and I will put it in a little perspective, not that I'm giving them a pass at all, I'm not. But when you look at overall cancer care, and I'll show you a couple slides on this, out of a study that Milliman did looking at Medicare and commercial data from 2004 to 2014. If you don't know, Milliman is one of the top actuarial firms in the country, that basically drugs and cancer care only relate to only 18 to 20% of the pie. We obviously have other problems in terms of we have new technology in terms of drugs coming out, and the demographics with people living longer and staying and surviving cancer contribute to it. I believe everybody's a part of the problem. That even includes community oncology. It certainly includes hospitals, but I think it starts with the FDA, and I think insurers are part of the problem as well as PBMs and certainly the companies. So a little look at some data. Don't sort of wince at the description, the legend for the pie chart, because I'll show you that in bigger type in a minute. But these are two pie charts. The ones on the top, the two on the top are Medicare data from 2004 to 2014. The two on the bottom are commercial data. And what you want to really look at are these blue pies, if you will, because that is the drug piece. So in 2014, drugs on the Medicare side were 18% of the pie in terms of treating cancer care, and on the commercial side, they were 20%. This study, by the way, if you're interested, is up on the COA website, www.communityoncology.org, and it's actually a fascinating study at looking at what has happened to cancer care from 2004 to 2014, the study period. These are the cost drivers of cancer care, and they vary over the study period. So basically, over the study period, 2004 to 2014, on the Medicare side, we've seen the cost of cancer care rise by 36%, and the commercial 62%. What obviously strikes out, if you look at all of those costs, and some are actually under the growth rate, but really what strikes out is specifically biologic chemotherapy. That should come as biologics. That should come as no surprise to anybody. Up over 335% and 485%, respectively, Medicare commercial over the study period. So that's what's driving it. What's being offset is by surgeries and in-hospital inpatient admissions, especially in the Medicare side, not keeping up with the overall growth rate. The drug pricing, I can tell you, is not a clean picture. Yes, drug companies need to do a better job. Yes, they need to do a better job in setting prices. Yes, there is a problem. There is no doubt about that. But I can tell you it's not a clean picture. If you look at data, and this was done by the Berkeley Research Group, if you look at the share of 2015 initial gross drug expenditures that are realized by manufacturers, by the brand manufacturers, it's 39 cents on the dollar, and by the generic, it's 19 cents. So you have a whole big pot of money, 40%, that are going to a lot of middlemen in the equation. Nothing is free in life. So when you give out a discount, or a drug manufacturer is required to give out a discount or a rebate, it ends up being factored back into the price. I can tell you that for absolute certainty because I've talked to that many companies. Turning to the 340B discount program, which is a discount program where manufacturers are required to give. This is some data also out of the Berkeley Research Group, a different study, but the orange bars represent basically hospitals that have 340B discounts, and the blue bars represent hospitals that don't. You can see enormous growth in terms of the growth, so much so that in the hospital outpatient market, 62% of oncology drugs are in 340B hospitals. So that's a huge amount, and the only reason why I say that is because, again, no discounts and rebates are free. So all of those discounts are going to go back in factoring when a manufacturer thinks about their drug price. There was a GAO report. Those of you who don't know, the GAO is the Government Accountability Office, so this is sort of the neutral government body. And you can see just by the headline there on 340B, action needed to reduce financial incentives to prescribe 340B drugs at participating hospitals. This is a quote. I won't go through and read it, but it does say it also has that basically, it says it also has direct financial benefit effects on beneficiaries who are responsible for 20% of their Medicare payment. And it talks literally about the appropriateness because it says at these hospitals you see more and more expensive drugs. So again, another problem. One of the other problems are these pharmacy benefit managers. So this relates to Medicare Part D, or the oral drugs. And as you know, we're seeing more and more oncolytics, oral oncolytics coming through the pipeline, such that you may have 35% of the oncology drug pipeline in oral oncolytics. And these PBMs are really coming on attack. They were basically formed and they were empowered by the Medicare Modernization Act of 2003 to basically help bring down and keep the cost of drugs. But the problem is that it's a different thing. And this graph, which was actually put out by CMS, the Centers for Medicare and Medicaid Services, shows it all. From 2010 to 2015, PBM rebates. So what that means, for those of you who don't know, that rebates that PBMs, these pharmacy benefit managers, extract from the pharma companies, and these are back-end, the rebates, discounts are up front, 340B discounts are upfront, these are rebates, have grown from 11% to over 17% of all gross drug costs. That is huge. And again, once again, that those back-end rebates get factored into the price. And I can tell you without going through it, because I can spend 5 hours here showing you data, that it goes back into the price. So when a manufacturer sets a price, and let's say they want to get $10 basically, and they're giving 50% rebates away, which is the case now, they have to think about setting a price at $20. So again, not defending, I'm just telling you this is a very complex picture, and as a result, Washington and legislation are looking at some of this complexity. So I'm going to stop here. 2 last things. We have a conference in the Gaylord National. Imidex is actually our CEU provider. We have about 1,300 people coming this year. And there's my contact information if anybody wants to hear more of this. My wife says, I don't know why anybody would want to hear about any of this, especially when they ask me to speak at lunch or dinner. She said I would just throw up. But that's it. That isn't my wife. That's Joan London. I had the pleasure of interviewing her. She was a keynote speaker at our conference last year. And this year it's going to be Scott Hamilton, who won the 1984 gold medal in figure skating, and just a great guy. So thank you very much, and I got about 8 minutes to answer any questions.